We're good. Guys, I'm Dr. Justin Sherman. I'm the medical director of Medical Optometry America's third eye care center in Horsham, Pennsylvania. And today, the slide advancer's not working. So I think I need a battery. Do we have AAA batteries?
Yeah.
One moment, please.
Yeah, thanks. I think you were looking.
I don't know if it doesn't need to be in close proximity there. No?
All right, this is our first streaming bottle. It's bound to happen at some point. But today, I'm going to talk to you guys about glaucoma. I wanted to start with this picture because it's so profound. So the left panel is a very healthy, normal-looking optic nerve. When I look into the microscope at a patient's optic nerve, it looks like this kind of orangish ring of tissue. It's actually made of about 1.5 million nerve fibers. And this is all very normal, healthy vasculature, normal, healthy retinal tissue. And what happens in glaucoma is you lose those nerve fibers. As you lose nerve fibers, the little excavation in the optic nerve, we call it the cup in the disc, it kind of looks like a hole in a donut, it enlarges. So here, in this photograph, you can see, or you can appreciate that the hole in this donut, instead of being maybe 25 or 30% of the tissue, closer to something like 90%, this patient has lost a significant amount of their optic nerve fibers. There's been an incredible amount of damage, and this would be somebody who had severe or was close to end-stage glaucoma. And we have other imaging technology that helps us quantify these measurements. Again, a normal healthy optic nerve, the hole in our donut here is about 30 to 50% of the donut, and you can see all of the tissue thickness indices on the left side of this readout are all normal. And then on the right side, again, the hole in the donut or the cup in the disc is significantly larger, 90%. And we have multiple sectors of the optic nerve that have abnormal tissue thickness indices. So it's easy to quantify how many fibers a patient's lost to glaucoma, or how much of their optic nerve anatomy has been lost to damage. What is challenging is explaining field loss to patients. When a patient gets their visual field report and they look at it and they see black in their grayscale field report, and they say, well, I don't have any part of my vision that doesn't work. And what I tell them is, in this grayscale, this doesn't mean these areas of your visual field aren't functioning. It means those areas of your visual field are abnormally weak. So as soon as the machine algorithm detects there is a 95% chance that that field point is abnormal, that gets a black square. And it's great for me because I know it makes it very obvious for me where a patient's visual function is low, but it's very difficult for a patient to understand that we're not looking at, they're not blind here. This patient has 20/20 vision. This patient has 20/20 vision. This patient has 20/20 vision. So on and so forth. And maybe finally at this point, when a patient has lost 80 to 90% of their optic nerve fibers, do they finally feel like they're beginning to have a problem? And that's about how much of your nerve fiber you have to lose in order to become a symptomatic patient. But if you get there, you are dangerously close to total blindness. You will feel like you lose your vision very rapidly. And the optic nerve has become so fragile that the little bit of vision that you have left when you become symptomatic is very challenging to preserve. In my mind, if a patient ever gets here under my care, that means that I've failed. And some patients, there are glaucoma specialists who see patients like these two, all day long, every day, and it's challenging to be the last person to see, an end-stage glaucoma patient before they lose their vision. But we need to, long before we get even here, again, on our optic nerve tissue scans, we can see changes that are abnormal long before anything shows up on the visual field. We call it pre-parametric glaucoma, or before glaucoma before the visual field. That is when we need to catch patients. So how do we catch somebody who is completely asymptomatic, but maybe has early glaucoma? Maybe they have some very subtle changes in their optic nerve tissue measurements, but their visual field is totally normal. Maybe this is a patient with 20/20 vision. They don't wear any glasses, so they don't see an eye doctor on a regular basis. First and foremost, the most important thing to communicate to patients is their level of risk. Your number one risk for developing any type of glaucoma is elevated intraocular pressure. After elevated intraocular pressure, your next strongest risk factor is a family history of glaucoma. So there are some studies that suggest if you have a first-degree relative with glaucoma, your risk of developing glaucoma yourself at some point in your life is about an order of magnitude 10 times greater than the average person. Glaucoma becomes much more common in patients over 55, if you're of Black, Asian, or Latin ancestry, that increased risk begins at 45. If you are diabetic or have sickle cell anemia, we think there is a role that decreased ocular perfusion plays in some glaucomas, especially what we call normal tension glaucoma that happens when a patient's pressure is statistically normal. And then the thin cornea is something that's not particularly well understood, but we understand it to be true. Patients with elevated intraocular pressure, specifically patients with high eye pressure and thin corneas, are much more likely to have progressive, difficult to control glaucoma than patients with high pressure that have thick corneas. Patients with thick corneas are much less likely to progress and have difficult to control glaucoma. Our patients with high refractive error, so patients who are very, very nearsighted or very, very farsighted, are much more likely to develop glaucoma. Just that has to do with abnormalities in the anatomy of the eye. Any type of trauma, so an eye injury or eye surgery, can induce a type of secondary glaucoma. And steroid use, about 1 in 10 patients will have increased eye pressure if they're taking a steroid. And not all of those patients will have an increase that's significant enough to cause glaucoma, but a good portion of them will. And there's a lot of different types of glaucoma. This is another thing that's really difficult to explain to patients, like, how do I have glaucoma? Where did my glaucoma come from? Most of the time it's genetic and you just kind of got dealt a bad hand. You've got sort of what most of us think of when we say glaucoma is primary open-angle glaucoma. So typically patients are completely asymptomatic until the disease is very severe, and about half of these patients will have normal pressure. So it's not enough just to get a pressure screening. You should really have, your doctor should be looking carefully at the optic nerve in the microscope, and you should be getting imaging that quantifies the anatomy of the optic nerve. You can have an optic nerve that looks very sick, but when we measure the thickness of those tissues again, our thickness indices come back very normal. And that is somebody who might just have unusual ocular anatomy. It's kind of being born with, flat feet. It's not necessarily there's anything wrong, but your anatomy is a little different. Narrow angle glaucoma, those are patients who tend to have very high plus prescriptions. That is because their eye is shorter and they have a narrow angle structure. It typically doesn't cause any damage until a patient has an angle closure attack. Angle closure for a patient experience is the eye becomes very red, very painful, the vision becomes very blurry, you get light sensitive. Sometimes the pain is so bad that the patient becomes nauseous and begins vomiting. But an angle closure attack can be blinding over a period of hours. So when a patient has an angle closure attack, that's a true ocular emergency. The patient needs to have their pressure lowered and an iridotomy immediately. There's pigmentary glaucoma that's related to iris anatomy that induces pigment release. You can have inflammatory, which leads ultimately to neovascular glaucoma. The eye is chronically inflamed. You can have fibrous scar tissue begin to develop in the eye, and that inhibits the drainage of the eye's fluid. You can have angle recession, and usually it's related to injury. Pseudoexfoliation is another type of glaucoma related to the lens structures in the eye releasing what we call pseudoexfoliative material. And then again, you can have steroid-induced glaucoma. The commonality of everything but our open-angle glaucoma is that these all result in increased intraocular pressure. So how do we treat that? Primarily we treat glaucoma with pharmaceutical agents, with eye drops. For patients who have emergency situations, there are powerful diuretics that we can use to lower the intraocular pressure. But the vast majority of patients with what I would call sort of garden variety glaucoma, lowercase g glaucoma, can be very well controlled with a single drop at night before bed, or one drop in the morning and another drop in the evening. Many patients do wonderfully with in-office laser procedures. This is probably my favorite thing to do with new glaucoma patients, is send them to have a laser done. The lasers are wonderfully effective. A laser procedure replaces about one pharmacologic, but they're wonderfully effective. And I would say if I had glaucoma, or if somebody that I loved had glaucoma, I would want them to very strongly consider having one of these laser procedures done before they started any eye drops and medications. And then there's some minimally invasive procedures. In the United States, the vast majority of those are only FDA approved to be done with cataract surgery. And it works pretty well. Most, glaucoma becomes much more common after 55. Cataracts become much more common between 65 and 70. So a patient may have had a laser or be on a drop, and then when they have their cataract surgery done, there's a procedure that they can get done at the same time that maybe makes it so they don't need drops anymore. The minimally invasive procedures are phenomenal. They're very, very popular in Europe. In Europe, they're typically done as a standalone procedure, long before patients have cataract surgery. Again, patients develop glaucoma 45 to 55, patients have cataract surgery when they're 70. Rather than wait, 1 or 2 decades for damage to be done, they just go ahead and have these procedures done. You can have them done in the United States as well, separate from cataract surgery, but most insurance companies will require that you pay out of pocket. That would be considered non-covered service by most insurance companies. And then there's incisional surgery. So for patients with the most severe refractory cases, we can actually remove segments of the iris and create a drainage pathway to the subconjunctival space to the white of the eye. And those patients end up with what we call a bleb. It is not pretty, it's not ideal, but it's very functional. Thankfully, our pharmaceuticals and our less invasive procedures are so good that it's pretty rarely done any longer. I think most patients having procedures like what we call trabeculectomy is what I described, where we remove iris segments and create those drainage pathways to the subconjunctival space, probably done in eye hospitals and teaching facilities. It's much less common for those to be performed by regular ophthalmologists. Most ophthalmologists are doing these minimally invasive procedures. But this is what you should take home, really. Glaucoma is primarily genetic. There's very little that you might have done or that somebody else might have done that could have given you your glaucoma. Just the way some connective tissue disorders or hereditary inflammatory disorders manifest later in life. Say, rheumatoid arthritis is a great example. Patients are like, well, how did I get rheumatoid arthritis? Well, it's primarily genetic. It doesn't come on until quite a bit later in life. Glaucoma is similar. Primarily genetic, it doesn't come on until later in life. Patients, you will be asymptomatic. Patients, again, are asymptomatic until their optic nerve looks like this and the visual field looks like this, at which point you're dangerously close to blindness, and the optic nerve has become very fragile. It is insidious. That's kind of my favorite word to describe glaucoma. Insidious means harmful at a rate that is undetectable. So this is glaucoma. Glaucoma damages your vision so slowly, you're unaware that it's like aging. Nobody feels that they're aging. Most old people can't tell you the day they got old. They say, oh, I don't know, one day I woke up and I was old. These patients, one day they wake up and they can't see. And they wonder what happened. Where in reality, glaucoma has been damaging the optic nerve for a very long time. And now they're beyond the threshold, so now they're visually symptomatic. You age every day. When you have glaucoma, glaucoma is undetectably harming you every single day. And this damage is irreversible. The damage done from glaucoma, there's no bringing those nerve fibers back. And it is blinding. The end of untreated glaucoma is blindness. Early diagnosis and intervention is key. And with early diagnosis and intervention, the vast majority of patients can be treated and cared for without ever becoming visually symptomatic. And that's the difficult thing to communicate to patients. If you've managed your glaucoma population well, you don't see anything. You don't have sick people that get better. You don't have blind people who are beginning to see again. That's something that we can't do. But you have healthy people who stay healthy. And that's how you manage glaucoma. That's it. Do you guys have questions about glaucoma or minimizing your risk?
What is the race factor with glaucoma? Like, why is it more prevalent in certain races?
So we're not sure. There are some races that tend to have just different optic nerve anatomy. And we think it is that difference in anatomy that makes them more prone to developing glaucoma. It's just like, you know, the taller you are, the more likely you are to have back problems, right? So we think it is this different optic nerve anatomy that, again, Blacks, Asians, and Latinos tend to have that predisposes them to glaucomatous damage. It's actually interesting. A lot of the big glaucoma studies they tell us a whole lot about how glaucoma works in white people. There are very few large studies done on glaucoma in ethnically diverse populations. It's kind of a shortcoming of the research. But I imagine as our understanding of glaucoma changes with devices like the FNAT. So we have a new device where instead of measuring intraocular pressure, you can actually measure the flow of fluid out of the eye. And we think being able to understand glaucoma in different ways may shed some light on that eventually. Anything else, guys?
So can this be detected like during a routine eye exam?
So the answer is yes and no. So if you are somebody who's very early, somebody who's much closer to normal optic nerve anatomy, then this severe disease, nobody's going to miss this, unless, you're really not looking. Somebody's going to look in and say, you definitely have a problem. If somebody's looking at the optic nerve, severe glaucoma is relatively easy to detect. It is when you're somewhere between here and here. You want to have an eye care physician that has the diagnostic equipment to watch you for changes. I tell patients all the time, about 1% of the overall population will develop glaucoma over the course of life. The incidence is about 1%. Incidence of glaucoma suspicion is about 10%. So 10% of the population looks like they might have glaucoma based on their anatomy, and those are the people you should run diagnostics on. And then about 10% of the people who are suspicious for glaucoma actually have glaucoma. So most of the time, if you're a practicing physician, you should have far more glaucoma suspects than you have glaucoma patients, unless you're like a referral center. So the answer, yes, you will find things that look suspicious on your regular exams, but you need somebody who has adequate diagnostic equipment because you can look very much normal, and it's hard to tell looking at a photograph. When I look in the microscope, I have both eyes, and you can kind of perceive the depth of things. But you might say, oh, this edge looks kind of steep there. It looks like maybe some tissue is missing. And then I could say, oh, I'm going to run some diagnostics. And you might find 1 clock hour of these thickness indices is abnormal, and then that's somebody whose risk for glaucoma is relatively high. That's somebody you're going to watch more closely. And again, about half the time their pressure is going to be high. Unfortunately, it's the people with normal pressure tend to go much longer before being diagnosed. If somebody comes in and their pressure's high, they're usually caught pretty early. But yes and no. The trouble with glaucoma is there's no singular diagnostic test for glaucoma. If I think you have a broken arm, I send you to get an x-ray, and you and I can look at the x-ray together and say you very clearly do or do not have a broken arm. You know, there is a fracture, it's displaced or non-displaced. When you have glaucoma, it is a progressive optic neuropathy. Somebody can have damage that looks like this from a type of like vascular event to the eye, something like a stroke that's happened in the eye. But the optic nerve will look pretty different. Rather than looking excavated, it will look pale. So there isn't a single test that we do that diagnoses glaucoma. The physician kind of has to look at your pressure and your anatomy and your family history and the results of your diagnostic tests. I would say your routine exam is the first step, right? The only way to detect glaucoma early is to detect it when the patient's asymptomatic. This is what I tell everybody. You should have, and we call it an annual eye physical. You should have a very thorough dilated eye exam every year where your doctor is doing these types of diagnostic tests in a screening manner to detect disease as early as possible. Anything else, guys? All right, thanks for coming. That's the end of the stream. Have a great weekend. Happy Mother's Day.